Так, презентация будет на русском языке, потому что на английском я, к сожалению, свободно не разговариваю. Вот. И, уважаемые судьи, сегодня я хотел бы вам презентовать клинический случай удаления зуба, немедленная имплантация, сразу же установлена временная коронка и отсроченный результат через год постоянного протезирования. Немного хочу рассказать о себе. Я врач-стоматолог-хирург, имплантолог, опинион-лидер компании MegaGen, вот, автор публикаций в международных журналах и обучающих видео, спикер, провожу обучающие курсы. Хирургией занимаюсь с 2016 года, закончил Российский университет дружбы народов на кафедре челюстно-лицевой хирургии. Мой клинический случай, да, как я уже сказал, это удаление 14-го зуба по европейской классификации, да, это первый премоляр. Немедленная имплантация, был установлен имплантат компании MegaGen MegaMind, пластика десны и временное протезирование. Ну, как мы сейчас знаем, да, в наше время, да, пациенты не хотят долго ждать и ходить без зубов длительное время. Поэтому наша задача первостепенная – реабилитировать пациента по возможности в кратчайшие сроки. Желательно реабилитировать его здесь и сейчас. Вот хочу презентовать такой клинический случай, да, то есть непосредственно обратилась пациентка с жалобами на боль в области первого премоляра, да, то есть 14-й зуб. Вот он. После диагностики было выявлено перелом стенки зуба, да, с небной стороны, очень сильный дефект. И, как мы видим уже на этой фотографии, начался уже у нее пародонтальный абсцесс. Вот этот дефект, да, то есть понятно, что зуб такой очень сложно спасти, практически невозможно, да, то есть тут у нас по этому рентгеновскому снимку все показания на удаление. Было проведено травматичное удаление этого зуба, да, с разъединением корней по бифуркации. Вот таким методом, да, то есть мы видим очень хорошую перегородку, да, в области соединения корней, да, что позволяет нам благополучно сюда установить дентальный имплантат. Планирование. 90% своих работ на имплантатах мы проводим через цифровое компьютерное планирование. Я считаю, что это очень важно, потому что есть все условия для того, чтобы работать по навигационным хирургическим шаблонам. Тем более компания MegaGen полностью оцифрована, да, у них есть все инструменты для того, чтобы работать, устанавливать имплантаты InReach по шаблонам. Вот пример цифрового планирования, да, то есть где мы видим плотность костной ткани, да, предполагаемой переимплантационной области. Был изготовлен навигационный хирургический шаблон. Немного исследований, доказывающих, что использование навигационной хирургии благоприятно сказывается на дальнейшей перспективе и обслуживании дентальных имплантатов, да, потому что мы четко понимаем позицию имплантата, потому что планируем именно от будущей ортопедии установку дентального имплантата. Также есть небольшое исследование, доказывающее применение бесстулочных шаблонов, что я в своей практике применяю 100%, да, потому что прибегая к стулочным шаблонам, да, то есть опираясь на это исследование, четко видно, что все равно есть какие-то небольшие отклонения, да, то есть от вертикальной оси, нежели если использовать бесстулочный шаблон, что и доказано было на моей практике, да, что используя втулочные шаблоны, да, то есть не всегда получалось добиться именно той позиции, которая была при планировании. Вот. Следующий этап, да, то есть это установка дентального имплантата. Был установлен дентальный имплантат компании MegaGen, модель имплантата INI-RICH, размер 4,5 на 10. Была достигнута довольно хорошая первичная стабильность, порядка 45 ньютонов на сантиметр. Вот. Что позволило непосредственно в этот же день провести пластику мягких тканей в этой области и отпустить пациента с временной коронкой. Вот. Также хочу поделиться небольшим исследованием, доказывающим, да, что на верхней челюсти костная ткань довольно мягкая, да, и чаще всего именно плотность костной ткани, да, то есть density порядка где-то D3, D4, но используя имплантаты с прогрессивной резьбой, спонгиозные, да, мы можем добиться в такой костной ткани хорошей первичной стабильности, да, соблюдая протокол препарирования. Вот. Следующий этап после установки дентального имплантата – это пластика десны. Также, да, то есть опираясь на исследования, доказывающие, что увеличение фенотипа мягких тканей в переимплантационной области максимально благоприятно влияет на исход, да, то есть и перспективу выживаемости будущего имплантата. Также это очень важно, да, то есть когда мы работаем именно в эстетической значимой зоне, когда у пациента, да, то есть есть зона улыбки. Вот такой слайд, да, то есть где была выполнена установка временного абатмента, да, то есть либо формирователя десны, и проведена мягкотканная пластика. Это уже этап наложения швов, когда, да, то есть мы уже уложили трансплантат в расщепленный лоскут между слизистой и надкостницей и фиксировали его монофиламентными швами. Следующий этап – это изготовление временной коронки. Так вот выглядит временная коронка, да, то есть она была изготовлена лабораторным этапом, да, то есть доктором-ортопедом, да, то есть я работаю только как хирург, и совместно со мной в команде есть доктор-ортопед, который, да, то есть изготавливает временные коронки. Эта временная коронка была изготовлена непосредственно в кресле и фиксирована пациенту. Да. Рентгеновский контроль после хирургии. Вот. Мы видим, да, то есть на этом снимке, что стабильность имплантата довольно высокая. Из-за того, что имплантат имеет довольно хорошую прогрессивную резьбу, да, по сути, у него очень хороший высокий бик, да, контакт поверхности имплантата с костной тканью. Вследствие этого, да, то есть не приходится зачастую подходить к аугментации лунок при немедленной имплантации. Потому что благодаря резьбе Knife Treat, да, то есть у нас очень хорошее получается пространство между резьбой, куда попадает у нас кровяной сгусток. И вследствие этого происходит сокращение сроков остеоинтеграции. Вот. Следующий этап, после того, как мы сделали временную коронку, да, то есть и уже после интеграции дентального имплантата, у нас следующий этап – это протезирование. Да. Протезируем мы полностью в цифровом протоколе. Да, то есть мы уже давно-давно ушли от аналоговых методов протезирования. Да, и сейчас мы абсолютно, да, то есть перешли в нашей работе на цифровую методику при помощи интраорального сканера. Вот так вот выглядит макет постоянной коронки. Да, то есть техникам в лаборатории был изготовлен проект, да, на котором мы видим в программе Exocad, как будет выглядеть будущая коронка по форме, да, то есть, соответственно, полностью, да, зубу антагонисту, можно сказать, что практически форма зуба отзеркалена. Мы видим четкое расположение шахты дентального имплантата, что благодаря цифровому протоколу и работе по навигационным шаблонам хирургическим, да, то есть мы всегда четко попадаем в центр будущей коронки, что благоприятно влияет, да, то есть на этап постоянного протезирования. Вот так вот выглядит слайд непосредственно перед фиксацией будущей ортопедии. Мы можем хорошо оценить профиль прорезывания будущей коронки. Да, то есть мы видим, что мы полностью восстановили всю архитектонику и биологию мягких тканей. Да. Имплантат довольно находится в оптимальной позиции. Да, то есть у нас есть наша заветная биологическая ширина в достаточном количестве. Вот. Это этап сканирования, да, то есть когда мы уже при помощи скан-абатмента проводим сканирование перед протезированием, да. Ну и результат через год, да, то есть будущее, как это выглядит все. Вот так вот выглядит эта выполненная работа через год. Пациента максимально эстетически она удовлетворяет, вот эта область, да, то есть где была выполнена имплантация. Мы видим, что полностью, да, то есть по зенитам, да, идеальное у нас соотношение, да, то есть вертикальная позиция имплантата, мезиодистальная позиция имплантата полностью соответствует тому, как должен находиться зуб. Вот. И, соответственно, также важен очень эстетический момент, да, то есть как выглядит сама коронка, да, что спустя год она практически ее невозможно отличить от своих зубов, что мы делаем в своей каждодневной практике, стараясь удовлетворить функциональную и эстетические аспекты наших пациентов. У меня все. Спасибо большое за внимание.
Recording stopped.
Okay, thank you for your presentation. So,
Да,
okay,
You're looking so confused.
сейчас.
okay.
Рано.
So the result will be announced on 26th of July. So please.
My name is Vorontsov Vladimir. I represent the Medical University of WHIS, Russia, the city of Samara. Allow me to present a report of restoration of the dentition using a digital protocol. This work was prepared on the basis of the clinic of the Academy of Dentistry of the Medical University of WHIS. Under the leadership Bulanov Sergey Ivanovich, Doctor of Medical Sciences, Professor, Director of the Academy of Dentistry, and Safronov Matvey Vitalyevich, Candidate of Medical Sciences, Chief Physician of the Clinic of the Academy of Dentistry. Clinical case. The patient is 57 years old man. He turned to the clinic of the Academy of Dentistry with complaints of missing teeth, aesthetic defect, difficulty chewing food. For the protocol was conducted with the fixation of the initial situation. Diagnostic intraoral scan can be computed tomography. This slide shows photographs of the initial situation in the patient oral cavity. After studying the result of can-beam computed tomography, the patient was offered a comprehensive rehabilitation plan, which you can see on this slide. And diagnostic stage, preparation stage of upper jaw, surgery and temporary prosthetics on the upper jaw, and preparatory stage on the lower jaw, surgery and temporary prosthetics on the lower jaw, and finally orthopedic stage, permanent prosthetics. Diagnostic stage. First, this slide presents intraoral scan, maxillary, mandibulary, and bite registrat. Then functional diagnostics was performed, including axiography and myography. Next, modeling of a temporary wax-up prosthesis on the upper jaw. The plan of surgery on the upper jaw. It is planned to install for dental implants anyone. Modeling of surgical guide in program Real Guide. In next stage, surgery and temporary prosthetics on the upper jaw. First, position and fixing of the surgical guide for the pin installation. Then low traumatic tooth extraction. Installation of dental implants using a navigational surgical guide. All implants received a torque 45 Newton. Next, determination of the stability of dental implants using the device Penguin. All implants performed excellent performance. Then an X-ray was performed after the installation of dental implants. All implants are in bone tissue. Installation of multi-unit abutments and fixation of a milled plastic prosthesis. This is what the patient looks like on the day of surgery after fixation of orthopedic structures. In this slide, clinical picture at suture removal on the 10th day after surgery. Next stage, surgery and temporary prosthetics of the lower jaw. The plan of surgery on the lower jaw is planned to install 4 dental implants anyone. Next, installation of the dental implants using a navigational surgical guide. All implants received a torque 35 Newton. Next, determination of the stability of dental implants using the device Penguin. Next, this slide, installation of multi-unit abutments and fixation of a milled plastic prosthesis. This is what the patient looks like on the day of surgery after fixation of orthopedic structures. An X-ray was performed installation of dental implants. All implants are in bone tissue. Patterns. for inventions. The clinical case is confirmed by patents for inventions of the Russian Federation. X-ray 6 months after the installation of dental implants. Our implants are in bone tissue. And finally, orthopedic stage. After 6 months, the patient was fitted with zirconium dentures for the upper and the lower jaw. On this slide, there are photos of our dental laboratory. We have the opportunity to perform medical and dental. This is what the patient looks like 8 months after fixation of orthopedic structures. Result. The patients underwent comprehensive rehabilitation. Lower jaw, which includes functional diagnostics using a full digital protocol, remove teeth, installation of dental implants, anyone with immediate for the upper and lower jaw. Conclusion. The design of anyone implants are to you get stabilization in any type of teeth implants anyone allow to achieve axial integration in 99% of cases. The immediate load has a positive effect of the osteointegration of implants. Implants anyone are recommended for use direct dental implantation with immediate loading. Thank you for the attention. Special for the opportunity to present our clinical cases internationally. I hope my report was useful to you. Thank you.
Recording stopped.
Okay, thank you, doctor. Thank you for your presentation. So the judges, any comments?
No, not yet. Thank you.
No comments.
Okay, if so, the result will be announced on 20.
День. Рад всех видеть. Хочу предоставить клинический случай. Меня зовут Ладyrда Дмитрий, я из России, живу в Челябинске. Вот, хочу представить клинический случай. Обратилась девушка с отсутствием зубов, с разрушенными зубами. Это у нас снимок, боковые зубы разрушены. Был предложен вариант реабилитации по восстановлению боковых зубов верхней и нижней челюсти. С левой стороны мы видим разрушенный 24-й зуб, отсутствие 26-го зуба, разрушенный 27-й. Начали работать с левой стороны. Проведено удаление 24-го зуба, 27-го. Проведен открытый синус-лифтинг кристальным доступом. Установлены формирователи десны. В области 24-го зуба сразу же проведено сканирование для того, чтобы сделать временную конструкцию. Так это у нас выглядит на рентгене. В области 36-37 установлены имплантаты. Имплантаты MegaGen, MegaMind и сразу же установлены формирователи десны. Переходим на правую сторону. Видим, удалены зубы спустя 3 месяца. Делаем синус-лифтинг открытый в области 16-го зуба. В области нижней челюсти справа удаляем 47-й. И получаем такую картину. В области нижней челюсти справа установлены 2 имплантата. В области 45-47 проведена мягкотканная аугментация. Наложены швы. В области 16-го синус-лифтинг и также швы. Через 6 месяцев были установлены формирователи десны. Вот это, но на этапе временного протезирования, то есть в таком виде мы уже начали сканирование. Были изготовлены временные конструкции. С временными конструкциями пациентка проходила в течение 2 месяцев. Формировали десну, оттачивали боковые зубки, функцию прикус. Так это выглядит. И перешли на постоянное протезирование. Установлены циркониевые конструкции на имплантатах, винтовая фиксация. Вот таким образом клинический случай мы завершили. That's all. Thank you.
Recording stopped.
Thank you.
Hello, dear all. Before we begin, let me briefly introduce myself. My name is Kristina Medvedeva, and I work as a dentist, surgeon in the leading dental clinic in Russia by the name of Stom Praktika RF. 1 minute, please. You don't see my presentation? Почему-то не работает. Что? Oh, yes, it's okay. It's okay. Can we start again, please? Before we begin, let me briefly introduce myself. My name is Kristina Medvedeva, and I work as a surgery dentist in the leading dental clinic in Russia by the name of Stom Praktika RF. It's a great pleasure for me to meet you on this competition, and today I would like to share with you my clinical case in surgery experience, and hope you find it interesting. We are going to talk about the comprehensive rehabilitation of the patient who had a periodontal disease, starting from planning to implementation. Just to make a note, according to the global burden of disease, severe periodontitis was the 6th most prevalent condition in the world. The prevalence of milder forms of periodontitis was estimated to be as high as 50% globally. The consistent evidence shows that the patients with a history of periodontitis have a significantly high risk for development periodontitis completed to healthy individuals. A meta-analysis based on observation studies reporting patients with a history of periodontitis were 2.3 times more likely to have a peri-implantitis. The patients with an initial diagnosis of severe periodontitis, when compared to healthy individuals, demonstrated a profoundly higher frequency of implant sites with bone loss and deep pocketing. And when we come up with periodontitis and plan the implant therapy, it's very important. We must have a stable, supportive periodontal care. Demonstration of those multiple visits, it's mean good oral hygiene, good compliance, and lack of disease progress. Here you can see one of my patients. He's 56 years old, don't have systemic disease, but he had bad dental hygiene and have the periodontal disease. On this slide, you can see the patient's smile line with different facial expressions. And next, you can look at initial situation, frontal view, and side view in bite. And all necessary periodontal assessment were done, and you can see a periodontal chart. This display original clinical situation. According to the physical examination, X-ray diagnosis and clinical situation was made an initial diagnosis, chronic generalization periodontitis of the teeth of the upper and lower jaw, and partial secondary adontia of the upper and lower jaw. On the first visit, the patient was completed about the mobility of the anterior group of the teeth of the lower jaw. We can see the problems of the hard surface of the teeth as well as soft tissue and oral supported. Besides, if we pay attention to the X-ray picture, there's bone defect air. On this slide, you can see an occlusal view after tooth extraction, and some granulations were found around the teeth 3242. Next, you can see the process of removal of the granulations, and finally the situation where the granulations are totally removed. And the worst condition of the extracted teeth after they removed the granulations. On the next slide, you can see the bone block transplanted from the angel on the lower jaw. And here we made all necessary preparation of the bone block and bone tissue, and fixing of the bone plate with scraps in the difficult area. And finally, we made a suturing of the difficult area. You can see X control before and after treatment. And after 4 months, the patient come back and says that all my life I dreamed about the beautiful smile, and he was ready to the complex rehabilitation. We have and made operated periodontal examination and have periodontal chart after 4 months, and the results were slightly different according to the initial situation. You can see the results about the mid probing depth, mean attachment level, plaque, and bleeding on probing. On the slide, you can see the initial situation of the frontal view after 4 months, and side view in bite at the right, and side with the teeth separated of the right, and side view in bite at the left, and side with teeth separated at the left. We have a treatment plan. It's a periodontal treatment before complex treatment, during treatment at the dynamic visit plan after complex rehabilitation, total extraction, 6 NE1 implants in maxilla, 6 NE1 implants in mandibular, and soft tissue augmentation, immediate loading of the temporary orthopedic structure, and 4 months later fixed the prosthetic. We removed all teeth and placement of implants all on 6 sides. It's a number of teeth and number of implants. We have the plastic surgery of tissue in the area of implants with collection of gums and PRF, and temporary orthopedic structure and the mild titanium beam with zirconium dioxide. And we have the clinical examination. You can see initial situation is a frontal view, it's a lateral view at the right, and lateral view at the left. And initial situation of the upper jaw is frontal view and occlusal view, and initial situation of the lower jaw and frontal view and occlusal view. And X-ray examination, you can see on this slide initial radiograph, and by the number of teeth 1, 2, 1, 4, 1, 6, 2, 2, 2, 4, 2, 6, 3, 2, 3, 4, 4, 2, 4, 4, and the last one 3, 6, 4, 6. We have the digital planning. You can see the digital planning implantation position. First of all, it's the upper low. Implantation position planning by the 1, 2, 1, 4, 1, 6, 2, 2, 2, 4, 2, 6 implant position, and temporary fixation pin. The model of the surgery guide temporal of the upper jaw, the model of upper jaw with the teeth removed on the models, adaptation of the surgery temporal of the upper jaw, and the next, the lower jaw. You can see the implant position planning 3, 2, 3, 4, 3, 6, 4, 2, 4, 4, 4, 6, and the adaptation of surgery temperature, natural arrangement of the teeth of the upper and lower jaw, and virtual tooth extraction on the models, and technical arrangement of the teeth in the upper and lower jaw. And we have started the lower jaw. You can see the initial situation and occlusal view, and created of surgical access in the area of the missing tooth, and view after the creation of surgery access, the condition of the bone tissue after guide bone regeneration after 4 months, and created a place for implants in the area 3242, surgery guide of the lower jaw, surgery guide frontal view, and occlusal view. And you can see the placement of the implant at state 3-2, 4-2, and installation of the implant. Installation of the gums shape in the area of the implants, and gingival graft shaping and segmentation using the PRF. And we have plastic surgery of the soft tissue in the area of the implants 3-2, 4-2, using a gingival graft for the vestibular and palatine size, and the approximal surface, palatal and vestibular. Suturing of gums around the implants, and placement of implant at sides and 4-4, 3-6, 3-4, and 4-6. And you can see the view in the oral cavity on the implantation of the lower jaw, and the appearance of the patients after implantation of lower jaw, left, front, and right view. And you can see the next step, it's the upper jaw. The initial intraoral situation in the upper jaw, occlusal view. And after teeth extraction, frontal view, occlusal view, and the level bone of structure of the frontal part of the upper jaw, the level of the reduction of the bone structure of the frontal part. And we are using a piezosurgical device for the reduction of the bone structure and the state of the bone structure in the frontal part of the lower jaw. It's occlusal view, surgery guide of the upper jaw, and adaptation of the surgery guide, and occlusal view, placement of implant and sites 2-2, 1-2, 1-4, 2-4, 1-6, and 2-6, and installation of the gum shape in implant sites, occlusal view, and the gum graft harvesting and segmentation. Suturing in this area on the upper jaw. You can see the occlusion view in the upper jaw after implantation and X-ray control after implantation of the upper jaw. You can see 1-2, 1-4, 1-6, 2-2, 2-4, 2-6, 3-6, 3-4, 3-2, 4-2, 4-4, and the last one, implant 4-6. We have the revelation after 6-month periodontal chart. We have the very good results about the mean probing, mean attachment level, plaque, and the bleeding on probing. And you can see after treatment with temporary orthopedic structure, after 3 weeks in the upper jaw and it's the lower jaw. It's occlusal view of the upper and occlusal view of the lower jaw. It's view after treatment of the patient. Oral appearance after 4 months, the upper jaw and the lower jaw. And X-ray control after 4 months about the upper jaw and the lower jaw. And you can see the multi-titan beam with zirconium dioxide. And patient after treatment, you can see the front view and side view in bite and side view with teeth separated. And we have the revelation periodontal chart after the 10 months with implants. And we have the best results after 10 months and dynamics. And X-ray control after 12 months. And we have the dynamics periodontal chart with plaque, bleeding on blooding, mean attachment level, bleeding on blooding about from 4 exam. And the best results we have in 4 exams. It's very good results for me because it's very good stable of the gums and the patient after complex rehabilitation before and after. And the results I want to say about the successful comprehensive functional and aesthetic rehabilitation of the patient was carried out. A comprehensive periodontal examination was performed before the treatment, during treatment, and after treatment of the patient. A dynamic monitoring plan has been drawn up. And the stability of the bone tissue and gums was obtained. The hygiene index of the oral hygiene of the patient at a stable good value. It's very good. And after undergoing implant treatment, patient must be observed by a periodontist surgeon in the order to monitor the dynamics of the condition of the bone tissue, gums, and implants. We have the happy patient, and I finished, and thank you very much for your attention.
Thank you.
Recording stopped.
Thank you for your presentation.
Thank you for you.
The judges, any comments?
No, not from my side.
No comments. Thank you.
Thank you very much. Have a nice day. Thank you.
You too.
Bye.
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 I'm ready. Okay. Hello, my name is Semerikov Dmitry, and I am a dentist orthopedist and implantologist. Here is the initial clinical picture. We worked in a big team to perform the comprehensive rehabilitation. The surgical and orthopedic stage were performed by me. Difficulty chewing food and aesthetic dissatisfaction, dental plaque, destruction of 4 teeth, 5 missing teeth, presence of carious cavities of 5 teeth. Even without close considering, wear of teeth is obvious in this picture. In the intraoral photos, the absence of several teeth is obvious too. Scan of dentition. 8 teeth are destroyed and have failed fillings. Diagnosis. Partial secondary edentia of the upper jaw and lower jaw. Acute pulpitis of tooth 1-5. Chronic apical periodontitis of teeth 1-4, 1-6, 2-4, 2-7, 4-7. Dental caries 1-4, 1-2, 1-3, 2-1, 3-5, 3-7, 4-5. A plan was proposed. Treatment of teeth. Removal of 4 teeth. Augmentation with a bone block in the area of tooth 3-6. Placement of 8 dental implants. Manufacturing of crowns and veneers supported on dental implants and teeth. Tooth extraction 1-6. Implantation planning of the tooth 1.4. I always trust enriched implants because they are among 10 brands which got certified with the Trusted Quality Mark certification. Removal of the tooth 1-4. The work was carried out using a surgical template. CBCT after installation. Implantation planning of the tooth 2-7. Removal of the tooth 2-7. The work was performed using surgical template. CBCT after operation. Implants enrich and anyone have unique thread design, narrowed blades with rounded edge do not wedge, but carefully cut through bone tissue. Bone implant contact is higher on average by 50% compared to others. Dental implants with knife thread demonstrate high levels of stabilization. Implantation in tooth position 2-5. Plastic of soft tissues and installation of healing abutment. It's well known that thin soft tissue are associated with great bone loss in the area of implants. Planning of implantation of the tooth 3-6. There are exposed threads of the dental implants. Collection of a bone block. Modification of the bone block using a bone scraper. Collection of bone chips. Fixation of the bone block and introduction of bone chips in the area of tooth 3-6. Plastic surgery of soft tissue and installation of the healing abutment of the tooth 3-6. The pronounced cross structure of connective tissue collagen in the area of the tuberosities determines great stability of the transplantants, and therefore this zone is preferable. CBCT in position 3-6. Planning of implantation of the tooth 4-6. CBCT after installation of a dental implant in tooth position 4-6. Removal and immediate implantation in tooth position 4-7. Removal of the tooth 4-7. The work was carried out using a surgical template. CBCT after installation of a dental implants in tooth position 4.7. Plastic surgery of soft tissues and installation of healing abutment in the teeth position 4-6 and 4-7. Implantation planning in position 4-6, 1-6, excuse me. Implantation planning in position 1-7. Implantation of dental implants in the position 1-6, 1-7. Soft tissue plastic surgery was performed and healing abutment were installed. CBCT slice in position 1-6, 1-7. Installation of multi-unit abutments and scan body in the upper and lower jaws. Scanning the upper and lower jaw in centric relation for wax-up and temporary crowns. Planning the future shape of teeth taking into account bite, elevation, and digital wax-up. Digital wax-up and temporary crown modeling. Manufacturing of temporary crown support on dental implants. If an implant and abutment of the same diameter are used, the gap between them is localized in close proximity to the bone tissue, increasing the risk of its excessive resorption. Printing models with wax-up on a 3D printer. Making a silicone case. Making mock-up. Preparation through mock-up and control of preparation depth. Gum retraction. Preparation through mock-up and control of preparation depth. Scanning for the production of permanent structures. Next. Using the face bow to transfer the maxillary position pattern into ExaCAD. Photographs of the face and prepared teeth of the upper jaw to transmit information to the dental laboratory. Modeling of permanent structures. Here is also modeling of permanent structures. Adhesive cementation. This is a photograph after fixation of orthopedic structures 1 week later. Here you can see the results of treatment. I am very proud of this case and the patient was satisfied with it. The case was very complicated, but my team and I made it our best during this treatment. Intraoral photographs of the lower jaw before and after. Patient's face look way better and younger now. OPG after complete rehabilitation. So we fulfilled our plan and we have done treatment of teeth, removal of 4 teeth, augmentation with a bone block in the area of tooth 3-6, placement of 8 dental implants, manufacturing and installation of crowns and veneer support on dental implants and teeth. To sum up, for me, as for a dental surgeon and orthopedist, the case was a real challenge, and I believe that I succeed in treating this patient. Thank you for your attention.
Recording stopped.
Okay, thank you for your presentation.
Thank you.
The judges, any comments or questions?
No.
No, thank you.
Thank you very much.
Okay. So
implantology, I quickly realized what's the first and one of the biggest enemies of dental implant treatment. It's definitely the lack of bone volume. Exactly as many others, I started with different GBR techniques, but unfortunately, I didn't succeed. After some time, I found, I would say today, the most forgiving technique at all. Why? Because it's working with the best material ever. Do you know what I mean? Then good things started to happen. Maroš KopačkA, I came from Slovakia, Central Europe, and today I'd like to share my case in this amazing competition, MEGA'MIND 2024. The topic of my presentation is reconstruction of severely atrophic frontal maxilla. When my patient came first into my office, I saw big and really tough guy. Both hands were covered by tattoos. But even though he cried as a child, literally, and I immediately got it, how much pain and how big frustration is hidden behind his strong body. Patient was 34 years old male patient when we started the treatment. His chief complaint was missing teeth in his frontal maxilla for a long time. Generally, he is young. He has to be young because I'm 35. And healthy man with no disorders, and even he quitted smoking because he wanted to get teeth again. Clearly, huge gap in his frontal maxilla, the most struggling part for the patient, and also multiple missing teeth in both jaws. Clinically, we can just confirm that situation. There is huge gap in his frontal maxilla and short gap on the edge of aesthetic region. When I saw him for first time, my very rough and very first plan was to place 3 implants in his frontal maxilla in region 1-2, 2-2, and 2-4, and 1 more implant for replacing right upper premolar or short bridge supported by teeth. I imagine that situation from the frontal point of view. I saw these 3 implants in position 1, 2, 2, 2, and 2, 4. But guess what? When we took CBCT scan, there is definitely the lack of bone volume. In region 1, 2, there is horizontal bone loss. There is no way how to place implant without any kind of bone augmentation procedure. In region 2, 2 was the situation even worse because the crest was even thinner. And in region 2-4, there was the worst situation because there was not only horizontal, but also vertical bone loss, and there was combined 3D defect. Treatment plan was based on general rules of any kind of bone augmentation procedure. First of all, it was necessary to get rid of this patient of all infection sources and to learn him how to keep his teeth clean. After this crucial step, this patient had to underwent again professional teeth cleaning at least 1 week prior surgery, and he started to rinse with chlorhexidine 3 times daily. Because we were planning to work and to regenerate the bone in quite wild oral environment, we had to prescribe antibiotics. And this patient was under antibiotic prophylaxis. So he started with amoxicillin 1 day before surgery, and then he continued next following 14 days till soft tissue was closed. The very important step was 3D vertical and horizontal bone augmentation according to Professor Curie and also modified by Professor Gluckman. Professor Howard Gluckman describes over here his beautiful so-called bending or curving technique, which describes bending bone plates for using and curved bone defects in the anterior maxilla. But let me explain later. After bone healing, what usually takes 4 months, we placed 3 implants in required position. And after the osseointegration period, we do some soft tissue correction. And the most important step for each patient, the prosthetic phase, of course. So let's go to the bone augmentation. We can see here open flap, exposed bone, where is definitely bone loss in region 1-2, bone loss in region 2-2 in horizontal way, and in region 2-3 and 2-4, definitely 3D combined bone defect in vertical and horizontal way as well. For cases such like this, I prefer to use donor side of choice, what is usually external oblique line, or also called retromolar area. This area offers sufficient amount of bone volume with the least chance to injure some vital structure. I also harvested these bone blocks with a piezoelectric device, even though it's approximately 2 times slower, but it offers sufficient cooling, less chance to overheat the bone with future osteonecrosis, and it makes this procedure even more delicate. So I harvested 2 bone blocks. Each bone block was taken from each external oblique line. And because it's called split bone block technique, according to Professor Curie, I split this bone block into 2 thin parts, so-called bone plates, and I use this diamond-coated disc, with sufficient cooling, of course. In that way, we got these beautiful form bone plates. This bone plates works only as a biological membrane, but the pure gold, the real gold, is over here in this bowl. So next step was scraping and collecting bone chips from bone plates first, then from donor side as well, intraorally, and storing them under sterile saline solution in the surgical bowl to avoid any drying out of these bone chips. Then I prepared all bone plates in terms of getting rid of all sharp edges, corners, and smoothing all parts. This bone plate was also prepared according to Professor Blackman, and thanks to these small curvings created by this diamond-coated disc in the middle part of this bone plate, allowed to shape this bone plate to bend it according anteriorly curved maxilla. We can see over here the way how I fix these bone plates. On the right side of the picture, we can see 2 parallelly positioned bone plates. Why? Because it's the region of vertical bone loss, and we had to gain the bone volume also in height, not only in thickness. I used their banded bone plate. On the left side of the picture was just horizontal bone loss. So then we did there some boxes from buccal side of the crest. All the containers which we created was then filled with bone chips. These bone chips were condensed properly till we feel 1 complex unit under our fingers. Next following step was, of course, wound closure, and I prefer to use PTFE suture material. And in this case, I used double layer closure. First layer was composed by external averting horizontal matrix sutures, and then single interrupted sutures over it. On that panoramic X-ray, we can clearly see both harvesting sites and 10 microscrews holding the whole framework in right position for proper healing in this bone augmentation case. After 4 months of healing, I exposed the bone again and look at this beautiful reddish vascularized patient's own bone with its own immune system. We can compare the situation beforehand and afterwards, and there is definitely a huge difference. It was not an issue to place 3 implants in required positions, so I placed 3 MegaGen implants, and then I sutured this wound again with PTFE suture material. We can see here all implants on panoramic X-ray. And after the osseointegration period, what takes usually 3 months, we should proceed that case with soft tissue management. And I love this procedure with after all maxillary cases, because we have never ending. We have endless source of keratinized mucosa on hard palate. So this technique is called apical reposition flap. So I started palatally at least 5 millimeters from each buccal surface of implant and shift this palatal mucosa to the buccal side of each implant neck. Of course, this procedure is connected with implant uncovering. So I replaced all covering screws with healing abutments. But look at this common issue in this case. This is the discrepancy between inner circle and outer circle. What happens usually in anterior maxilla. I had to solve this problem. So I divided this flap, this shifted flap, into 3 portions. And I sutured then each portion to make it periosteum without muscle fibers to each implant neck. I used 6-0 suture material, monofilaments. Here is more buccal view. And here is the result after 14 days of flap repositioning. So healing is very, very fast. Here are some X-rays after replacing cover screws by healing abutments. And then we can proceed that case with prosthetic phase. What's the most important for each patient. So I followed my very first treatment plan. So I prepared this teeth for a short bridge supported by teeth. And these implants were prepared for scanning and for prosthetic phase and creating some implant supported bridge. Look at this incredible amount of soft tissue. Look at this incredible amount of bone. I love these procedures. I love all augmentation, all autogenous augmentation procedures because it's still the same story. It's like Robin Hood, taken from the rich and given to the poor. Then we continue with
Recording
scanning.
stopped.
Let's scan
Recording in
bodies.
progress.
And our lab fabricated this beautiful prosthetic work. Actually, 2 prosthetic works. They are separately on teeth and separately on implants. And look at this picture. So this is immediately after fixation. Of course, patient forgot how to clean his teeth, probably. And here is comparison before the treatment and afterwards. Here is the picture after 4 months. So 4 months follow-up. This patient, in each single life are the most important 3 milestones. When you are born, when you'll die, and when you'll be buried. This patient died in his 34, and he started to live again in his 35. Thank you for your kind attention, and I would like to wish best luck to all participants of this beautiful competition, the MEGA'MIND 2024. And if you'd like, you can scan my QR code and follow me on Instagram. Thank you.
Recording stopped.
Thank you so much.
Thank you for
Thank
your
you too.
presentation. Okay, so judges, any comments?
No, not yet.
Okay, so the result will be announced on 26th.
Okay. So I just stop. Okay. Hello, my name is Maciej Walczak. I'm glad that I can participate in this contest. I want to start with my presentation with some famous quote. The great things are done by a series of small things brought together. I believe in this sentence because in my everyday practice, I took a lot of these small things from many famous dental surgeons from all the world. And I tried to bring it together and create something unique for my patients. In my everyday practice, I work in Poland, in Wrocław, and I cooperate with many dental offices in which in this office's area of my expertise is bone and hard tissue regeneration. I create my original courses about microsurgery, bone and soft tissue regeneration using autogenous grafts. And today I want to share with you my way of treatment, how to use autogenous potential of our patients and how I use it in my everyday practice. We all know that when we talk about bone regeneration, we know that the rapid revascularization could happen when we use autogenous bone, and it helps with better healing, especially in this first period of healing. And in this moment, I want to show you one of the technique which I use is bone core technique. And this technique I use for unilateral small defects when I want to place implant at the same appointment. Of course, as many techniques, this technique has some difficulties. So we have to know how to work with trepine, which kind of bone, which type of bone we can cure with this treatment, because when bone is very soft, it could be difficult to take this kind of graft and do this procedure. But this procedure is very safe. So I like to work with my patients with this procedure because I can give them a good result with very safe way. Of course, this technique I use for small defects. When I want to manage with bigger defects, I have to remember that when I manage with external bone defect, it could be, I could expect more resorption using this technique. So I rather leave it for small defects. When I want to show you step by step how I do this, in case like this, it's horizontal bone loss. We can see that here we have oblique crest. I use this trepine to collect bone core. Then when I collect the bone core, I use the final drill for implant preparation. I place the implant. Then I switch about 90 degrees this bone core and press it to the bone and implant surface. I fill the gaps with bone chips, and after 3 or 4 months, it's possible to remove this screw. And then, of course, I expect some remodeling of the bone, but I have around my implant, I have pure natural autogenous bone of patient. I want to share you my first case. In this case, the 44 years patient lost his tooth 3.6 and tooth 2.6 was qualified for extraction. This is the photography after immediate implant placement in the upper arch, but we still don't have tooth 3.6. We can see that there is some lack of soft tissue, but to say anything about hard tissue, we have to do CBCT. And I did CBCT and scan because I always try to do digital planning for my patients. We always have to think about position of the implant according to prosthetic design of our crown. So I did some planning digital, and then I know that I have horizontal defect, and I will have to manage this defect during implant placement. The situation in occlusal view after reflecting the flap. I need to have about 8 millimeters of bone, and I have only about 4 millimeters. I use this special kit of trepine to collect the bone core. So I create the space for the implant. Then I have the bone core and the bone chips. The bone chips, in this case, I took with ACM drill from the linea obliqua. And then I place the implant and place the bone core. And in this moment, it's very important to put this bone core on the surface of the implant and on the surface of the bone. And the crucial thing is to stabilize this graft in a good way, because only if the graft is stable, if it has good stability, there is possibility to good revascularization of this graft. Of course, there is a second thing. I need some scaffold for new bone formation. So I use this graft, but in this situation, I like to use higher closing screw because it gives me more space for the bone chips. I can place the bone chips around this screw, so it gives me extra support. And the second thing is that in the second stage of surgery, it will be easier for me to find the implant. These are the bone chips over the bone graft. We can see on the labial view as well. And I use in this situation only autogenous graft, so it's not there's not any possibility, necessary to use any membrane, because I know that if I put somewhere the collagen membrane, it could stop the resorption of the graft. So I don't use the membrane in this situation. I only suture it over the graft, and it's very important to suture it in layering suturing, because the suture is crucial thing to have a good healing. After 3 months, I can expect a situation like this, but I can see, I know that there is bone somewhere inside, but I have to think about the soft tissue. Here, we have to remember that soft tissue is like a shield. It's like a shield for our bone. So we have to measure how much soft tissue we have. In this situation, I expect more soft tissue for my patients. So I decide to do free gingival graft. Create a space for the free gingival graft. We can see that this is only periosteum without the muscles, because I want to achieve a keratinized and stable tissue on top of the implant. And this is the free gingival graft from the palate. And I suture this free gingival graft on the periosteum with nylon sutures. Dressing of the palate, of course. And after 14 days, this healing looks really well, and everything looks really well, but it's only 14 days. This tissue is still not mature, so we have to wait. I wait extra 4 weeks, and after 4 weeks, I can uncover the implant. And during uncovering, I remove this last micro screw, and I can see how great amount of bone and how vital this bone is around the neck of my implant. So now I use a standard healing abutment, and after 2 weeks, I change this healing abutment for individual one, because I want to have greater emergence profile for my patients. And in this moment, I want to compare these two techniques, because in the upper arch, I had the individual immediate implant placement. In the lower arch, so it was only one surgery. In the lower arch, the patient has extraction of the tooth, then implant placement with grafting hard tissue, then soft tissue grafting, and uncovering the implant. So it's more surgeries, and still it's difficult to mimic nature as in immediate implant placement. So if it's possible, I try to do immediate, but it's not always possible. Now we can see emergence profile of the crowns and the prosthetic design of the crowns, prosthetic design of the crowns in occlusion. And because I'm not prosthodontist, I always see the patients. My friend do prosthodontist, but I always see the patients after 1 year of loading, because I want to check if everything is okay. And here is how it looks like intraorally. Tooth 2.6 implant in position of tooth 2.6 looks really nice. It mimics the nature quite well. And soft tissue looks very good. Now I will show you small history about this implant. This is before extraction. After extraction, I place the implant. In this situation, I place a little bit wider implant in position of tooth root, palatal root. So it's any reach 5.0 in this situation. Then after 1 year of loading, you can still see that everywhere bone looks really great and it functions really good. And situation in lower arch, we can see that 3-6 it's not so natural like 2-6, but the stability of the soft tissue is very good. We can see that there is papillas between teeth and implant. And on the CBCT, I can see that the bone around the implant is in really good condition and in really good volume. But this was the situation when I had a small defect. If I have some bigger defects, I cannot use this technique, as I said at the beginning. So the second case I want to share with you is with split bone block technique, the Curie technique. To do this technique, we always have to think about harvesting the bone. The harvesting the bone is very important because without it, we don't have material. In general, I use linea obliqua, sometimes chin, but in general, linea obliqua. Of course, even if I can feel that patients have this linea obliqua, I always do CBCT because we always have to remember about anatomy of our patients and to be safe of our patients. The second thing, we need to know good procedure how to harvest this bone block in the safe way. When I have this bone block, I can scrape it with the scraper and then cut it to the bone blades to have a possibility to create the scaffold for my new bone formation. And with this bone blades, I can mimic the cortical part of the bone, and with the bone chips, the sponge bar part of the bone. So I can achieve very natural, very high quality of bone with high bone to implant contact values in the future. And in this case, I want to show you this type of treatment. The 63-year-old woman who came to our office to change composite temporary bridges in the upper arch, but tooth 2-5 was we decided to extract tooth 2-5 because of the periodontal lesion in this tooth. And this is the photography after extraction and before regeneration. On the right side, you have CBCT, but CBCT was made before the extraction, but we still know that there will be just a defect in the bone. After reflecting the flap, I can see on the occlusal view that I have a big defect in the bone. And then using right angle technique by Professor Curie, I create the space for bone chips and then create the space for new bone formation in the future. Suture everything well. It's mandatory in this type of cases. We always have to close everything very well. OPG after regeneration, and then after 4 months, I can do digital planning in my patients. With the prosthodontist and the patient, we decide not to touch the sinus floor, so we decide to put 2 implants in position of 2-5 and 2-4 and 2-5, and do cantilever in the distal part. This is how it looks like bone after 4 months of healing. So everything is vital, and we cannot see much resorption of the bone. Then using surgical guide, I prepare space for the implant. I place 2 enriched implant subcrestally, and I wanted to manage this a little bit thin bone on the palatal side. So I took some bone from the tuberosity and place it on the palatal side as well. Suturing, as always, is the crucial thing to have a good healing in our patients. After 2 months of healing, I can manage with soft tissue and graft some soft tissue in this area. I don't want to touch implant. I don't want to touch this area where I did some regeneration, but I can manage with soft tissue. So I did a 3 gingival graft, and after 2 more months, I uncovered the implant. And this is situation 2 weeks after uncovering, when I remove the suture. I use here the astral technique to uncover the implants. We can see that there is a great amount of soft tissue around the implants. And this patient has for half a year temporary crowns on this implant because of wedding and family. And then after this time was delivery of final restoration. And this is the outcome of our treatment. After 1.5 years of loading, I can see that the soft tissue is stable around the implant. Patient is very happy because it's easy to clean for her, and it's in very good function. And on the CBCT, I can see that the stability of bone, I achieve stability of bone around the implants, and everything look really healthy. So we all know that we have a lot of tools in surgery. We all know that we can manage with different defects. We can think about different techniques, but these techniques are these small things. When we brought it together, we can create something unique, something great for our patients. Thank you for your attention. Maciej Walczak.
Recording stopped.
Thank you. Thank you very much.
Thank you very much.
Thank you for your presentation.
Thank you. Thank you for the opportunity to be here.
May I ask you a question?
Of course.
Nice presentation, nice cases, especially for the first presentation with the bone augmentation and the screws. Do you have any literature, because you didn't cite it that much?
About this higher screw for the implant plate.
For example, yeah.
I just see that it's helped me, because when I have only this smaller covering screw, because you asked about this covering screw, yes?
Yes.
When I use only this small covering screw, I always have problem because I have to drill the bone to find the implant. And you can damage the implant, you can lose some part of bone because you caused trauma. I think this is very helpful to put higher covering screw, and then it is easier to press well around this covering closing screw to press well the bone particles, and it's very stable. I don't have it was my idea. It just helps me to work in the easiest way.
Yes, not just a recommendation for future presentations, because I think you will use it for the future as your topic, because you're the bone guy, as you said in the introduction. Even if you have no literature on your own workflow, please look for some literature which is similar, using screws, using 10-pole screws, for example, because without literature, it's just eminence-based, it's not evidence-based. Very dangerous.
True, that's true. I know.
Nice presentation, anyway. Thank you.
Thank you very much.
Okay, so any comments?
Not from me. Thank you.
Okay, thank you very much.
Yeah. So the result will be announced on 26th of July.
thank you very much for the invitation. So today's topic is the fully guided partial extraction therapy as a standard of the 21st century. So it's a topic which is going around my presentation since 2 years. I try to do every partial extraction therapy case guided. Thanks to MegaGen, I can have my own kit to do it now. And I want to show you the very interesting case, which is very challenging actually. So starting with the socket shield or partial extraction therapy, I'm a huge fan of it, especially in aesthetic zone. I think it's nowadays is a standard to achieve amazing aesthetic result. So today's case is a double guide system with R2 gates. So I use an R2 gate as a base. I make a project of 2 guides. One is for the implant placement and another one is for the preparing the shield. So my case is the tooth number 13. There is extraction of the endodontic treatment canine, very long teeth. Here I plan 3.8 core, 15 millimeters enriched implant to achieve the most stability. And for the partial extraction therapy, I use even longer drills. By coming to the background of the planning in R2 gate, especially this kind of difficult aesthetic zone cases, we have a classification of sagittal root position in relation to the anterior maxilla. In the case of the implant placement, so we have a classification, what kind of connection between bone and the teeth we have. In this case, is the class 1, is from Jeff Kahn. And the correlation to this study is a study from our beloved Howard Gluckman, who add to this classification how we have to make a planning, where we have to drill, how we have to go with the bone. So according to both these literature cases, we can make a planning according to the good bone position and of course the prosthetic. And coming to the most interesting part is to creating the guide for the partial extraction therapy. In this case, we use 18 millimeters drill. I mix in this stage a guided kit and Howard Gluckman kit, and now my own kit for the partial extraction therapy. So in the case of this long tooth, I have to remember to hit the apex, to remove all of the gutta percha. And what is very, very interesting, if you will see on the left side of the case, where you have the axis of the root, it's completely different than the position of the implants. So that's why we have to use 2 guide system, because in the many cases in aesthetic zone, there will be completely different positions from the implant and from the partial extraction therapy guide. So this is how it looks in the mouth. The patient is a 34 years old gentleman with no allergies, no general diseases, general healthy. And what we see here, it's very big root, very long root. And if we go with the classic approach with the extraction and with the grafting and soft tissue grafting, the most crucial thing will be the extraction of the teeth. It was 22 millimeters root. So as you know, and very thin buccal bone, it's very, very difficult to do it and not to break the buccal bone. So in these cases, the PET should be considered as the first step that is much more predictable in the case of the surgery. So here we place our first guide, which is connected to the partial extraction technique. We drill through the guide. I always drill up to 3.3 millimeters drill, that I'm sure that I remove the apex and I make my PET thinner. I want to make it around 1.5 to 2 millimeters. So what is here very necessary to mention, that in the extraction socket like this, that is an aesthetic zone, and if we can avoid doing a flap to manage our post-extraction socket, it's much better. In this studies from Chu and Salamas, they say that's the best way is to graft the socket, to use the temporary, and to not elevate the flap. So that's how we do it here. So we prepare temporary, we will graft the gap, and we will not raise the flap. So as you see here, we have prepared the drills for the root. We remove the gutta percha, and now it's the most crucial thing is to separate the root and remove the palatal portion. So as you see here in the pictures, we have very important things that palatal root portion is removed. And what I love to see is that you don't have the apex, which is very crucial, especially if you will take into consideration that the root is above 20 millimeters, it's almost impossible to remove it free-handed. It's very difficult. It's almost a blind surgery. So that's why the guide is so necessary. So this is how it looks after removing. We know we have to prepare the shield. We use, of course, the Howard Gluckman kit, which is the best tool which you need to do the partial extraction therapy. So as you see here, it's separated. We have to go at least at the bone level and then make S shape from the root. We place here 4.5 implant in diameter with the core 3.8, 15 millimeters to get a good primary stability, the high ISQ value due to the big bone implant contact. So we put out the second guide and we make a drilling and we place the implant. So as you can see here, we have 3D guided implant position, which was planned before. We have space for the socket augmentation, which is necessary in these cases. And we see how we prepare the shield with the S shape and we go below the bone level. Of course, smart pack and ISQ in all of my cases is a standard procedure to be sure that we're doing a right decision in the case of the loading. 74, high ISQ value, and as we all know, everything above 70 in the case of the single units, we can load immediately. So we are on the safe side, we don't have to be worried. As you see here, we need to do the grafting, and the best way to graft around partial extraction therapy cases is the allogenic bone or autologous bone. In these cases, we use the allogenic bone, the very small particle, the smallest that we can get, 0.1 to 1.2 millimeters size. In this case, we use a temporary cylinder with the hex. Why with the hex? We have to remember that always the more anchorage which we have in the implant causes it that is more stable. So the temporary work, so temporary crown, will be much more stable and there will be no micro movement. If there will be no micro movement, then we will have no bone loss at the time of the healing. So it's very necessary to think about it during the preparation of the temporary solution. So here is our temporary crown, which will leave for at least 3 months. We have CBCT, and what we see in the CBCT, we have the shield, which is at the bone level. We have grafted the side of the space between the partial, between the shield and the implant. A very necessary thing which we have to think about it and take into consideration is depth of our implant. In this case, we are following zero bone loss concept from Thomas Linkevicius, so we have to go at least 4 millimeters from the soft tissue. Here we go a bit deeper due to the size of the socket. If there is another very, very important thing why we graft it and why I'm very huge fan of the socket shield, because these are the studies which are talking about implant socket shield. So somebody left the part of the root, placed the implant. After that, they realized, look, we have the root, we have to remove the implant. And when they make a histopathology trials between the bone which is formated between implant and the root, they found that is perfectly fine bone. So that's what we want to achieve, is to have the sound bond around our implants. After many years of studies, you can know that we don't want to use the xenograft material because for the long period we'll have the bone loss and the peri-implantitis will dramatically accelerate. In the case of here, we have the best possible thing, so we have sound autologous bone. 9 months later, the patient came because he's actually working abroad. Perfect soft tissue, perfect outcome from the aesthetic reason. There is huge papilla, very high papilla, so we achieve everything possible. So the good 3D position, we manage the grafting, everything. We started doing the scanning. Of course, with the digital approach, we make a scanning. And what I check here is I make some cuts from the first scan and I measure what is the width of the socket. And it came out as 8.977 millimeters. I did the same in the last scan when we take the impression, and it's almost the same after 9 months of the healing. So if I compare it in the day of the surgery and the 9 months later, we have a almost 0.2 millimeters difference. Of course, it can be occur some wrong calculation or some kind of miss of the software. But what I want to mention here, that after 9 months of healing, and in very difficult case, as we have the upper canine, which is a very big socket, we have minimal shrinkage of the soft tissue. So this is the reason why there is a high demand of this kind of procedure in aesthetic zone, that we can be sure that we want to lose a many bone, especially if we compare to the study which are from the team Atlanta, which I mentioned that we have to do the provisional and do the grafting. Here we do everything and more with the partial extraction therapy. And the same, there is another case of studies that shows there is a less shrinkage of soft tissue and bone comparing partial extraction therapy case and classic procedure with grafting and soft tissue. I've done many cases. Unfortunately, this case, I cannot show you the finish of the crown because the patient is working abroad and he will be next week in Poland and I will deliver him the final crown. But there are many cases which I done in the last years. I did around now 90 something cases for the partial extraction therapy. I done everything guided. And what is for me the most important thing in the whole concept, that we have very good aesthetics. We don't need many procedures, and there is a sound bone around implant. So we are very, very safe in the case of the long-term observation because we are minimalizing the risk of peri-implantitis in the case of the xenograft materials, in the case of overgrowing the soft tissue. So in this case, and in many, many, many cases, of course, the technique as itself is very sensitive. That's why I think the guided solution for it will provide it to be more used in daily practice for more dentists, and the dentist can deliver the high aesthetic, very difficult treatment for the more patients. As me, the partial extraction technique should be considered really as a standard of the 21st century cases, especially in aesthetic zone. Thank you for your attention.
Recording stopped.
Thank you for your presentation.
Thank you.
Thank you. Any questions, or there's no questions now?
This is no question session.
Oh, last year it was a question session. There's always, something, Marcus, more challenging.
The rules have changed. No question. Surprise when you will find out who's winning and who's not.
Okay, gentlemen, thank you very much. And
Hello, my name is Yordan Mitev. I live and work in Sofia. This is the capital city of Bulgaria. I'm a dentist. I'm an oral surgeon and work only in the field of oral surgery and implantology. My interests are microsurgery, bone and soft tissue reconstruction around implants. The topic of my presentation is full arch implant rehabilitation in lower jaw. The patient is referred to me from a colleague of mine who is anesthesiologist. He is with terminal dentition in the lower jaw. His periodontal diagnosis generalized periodontitis stage 4 grade C. He has some teeth and roots remained in the lower jaw, which are hopeless and they need to be extracted. In the upper jaw, he has a fixed dental prosthesis, dental bridge. The patient is 49-year-old male patient, but in poor general health. He has cardiovascular disease, he has heart failure, and because of his obesity, he cannot get into the waiting list for heart transplantation. He takes a lot of medicine, but he's a non-smoker and he has normal levels of vitamin D. Here we see the CT of the patient. As I said before, we have 2 teeth and roots remained in the lower jaw. The treatment options are removable partial denture, overdenture, and full arch implant rehabilitation. The one and only desire of the patient was to have fixed dental prosthesis on the lower jaw, so the treatment of choice is the third option. My plan is to do disinfection protocol first in 2 appointments. Then we're going to collect information and plan the prosthetic part of the treatment. I mean, aspects such as vertical dimension of occlusion, lip support, and attached tissues are critical, and they should be integrated into the future prosthesis. According to Karamesh classification for full arch implant rehabilitation, the patient gets into class 2. In my opinion, the most critical part of the surgery is obtaining initial stability. According to the literature, we need 30 newtons per centimeters of insertion torque value for each implant to perform immediate loading. So we are going to use techniques and implants with special design that are going to give us this upper unity. At this particular case, of course, I will use MegaGen enriched implants. The implants are going to be placed 4 millimeters below the pharyngeal margin. This is the vertical aspect of the biologic width we need to take into consideration. And of course, in front of the implant, we need to have at least 2 millimeters of buccal bone. Immediately after the surgery, I'm planning to take in preparation from the implant, send it to the lab, and fabricate temporary prosthesis, which the patient is going to use 6 months. And after that, we are going to fabricate definitive construction. Here we see pictures in the areas where I plan to place the implants. As I said, the patient goes into class 2 of Karamesh classification. This means that we can place 6 axial implants. Yes, there is some resorption in the distal part of the area, but it's moderate. So axial implants are going to be placed there. From this picture, we clearly see that the patient has decrease in the vertical dimension of occlusion. We have deepening of the nasolabial and mentolabial sulcus, thin lips, and hypertonic mental muscle. This is the initial situation in the oral cavity with the removal partial of the denture in the lower jaw. This is the initial situation without the partial denture in the lower jaw. First flap is reflected in such a way so that we can clearly see the mental foramens in the left and in the right side. Then bone reduction is done to remove any irregularities and to level the bone crest and to create enough vertical space, which is important for the strength of the future prosthesis. Mao guide was used to place the implants in the right position. All 6 implants have insertion torque value more than 45 newtons per centimeters. And some of them are placed around 1 to 1.5 below the bone crest. We have used supracrestal positioning of the implants to ensure that we have enough soft tissues in vertical direction. The multi-unit abutments from the right side are straight, all straight, but in the third quadrant, they're angulated to 17 degrees with the cuff height of 1.5 for the lateral incisor and for the molar, and 2.5 millimeters cuff height for the perimolar. This picture was taken immediately after placing after surgery is over. Unfortunately, I haven't photographed the next phase, but I will try to retell it. Impression copings were installed over the implants and were splinted with orthodontic wire and pattern resin. An open tray impression technique was taken and sent to the lab. On the next day, one day after the surgery, the lab sent us back walks up terrain and aluminum bar to check the occlusion and to check if there is a passivity of the bar. This picture was taken 2 days, 2 days post-op, and 1 day more on the third day. The provisional bridge was fabricated. It's made from PMA gingiva and acrylic teeth from a kit. This is the internal surface of the bridge. It looks flat. There are no irregularities in it. So by this way, we reduce the accumulation of food, debris, and we enhance the oral hygiene of the patient. This is picture immediately after delivery of the temporary restoration. I have filled the access hole with composites. And this is a picture of one happy patient on the 3rd day after the surgery. First removing of the bridge, more than a year after the surgery, the patient came back to my dental office and we removed the bridge, and it looked like that. The hygiene is very, very poor, and the bridge is broken on the left side. But the patient, as I said, had several heart operations, so he didn't take care for his oral hygiene at all. This is one more big picture of the appointment. This is taken immediately after removing of the bridge. Yes, there is still plaque accumulated on the multi-unit abutments, but the tissues, they look nice. They look very good. At this stage, again, I installed in preparation copings over the multi-unit abutments and took an in preparation with open tray in preparation technique. I sent the in preparation to the lab and then fabricated this jig with pattern resin between the in preparation copings. First, it was one piece, and then they cut it between the in preparation copings and send it back to my office. Then I placed the jig in the mouth, and in the cuts I put pattern resin and splinted the whole thing again. By this way, we assure passive fit for the future bridge, and also we're sure that there is no pressure and stress between the components. This is wax up with acrylic teeth to check the occlusion, and inside this wax up there is aluminum bar. First, we do passive fit of the aluminum bar. If everything is okay, then the aluminum bar is replaced by a T-bar with the same shape. Yeah, we do it by this way because it's easy if there is a problem with the impression. I mean, it's cheaper to do it again. This is the condition of the soft tissues immediately before delivery of the final prosthesis. Here is the soft tissue condition in details from the left side. Here is the condition from the right side. And it's the definitive prosthesis. It's made from the gingiva is from composite, and the teeth are acrylic from a set from a kit. Definitive prosthesis is delivered to the patient. It's almost a year and a half after the surgery. We clearly see that the access holes are on the lingual side, as they should be. This is the checkup around 1 month before today. The patient is happy, really happy. This is the clinical consequences of the patients, the initial situation, with the temporary reconstruction, and with the final bridge in the mouth. We see the OPG immediately after implants are placed. As we see, some of them are placed subcarestally with more than 1.5 millimeters. Some they are placed epicarestally. And this is a picture around a year after the surgical phase. We see corticalization and stable bone around the implants. Thank you very much for your attention.
Recording stopped.
Thank you.
Thank you. It was good to see you again.
Thank you. Thank you. Good to see you again too.
Judges, any comments?
No.
How about Dr. Ginevičiūtė? No? No, any questions?
No.
Okay. Okay, thank you for today. And the result will
Thank you very much. Thank you very much, my dear colleagues, dear friends. Nice to see you here. And for me, it's a big pleasure to be a part of MegaMind 2024. I wish you a good, positive mind. And I would like just to share with you some case report for my daily workflow, how it's work in my practice. I'm Dmytro Dziuba. I work and live in Estonia for 9 years. Basically, I'm Ukrainian from Ukraine, but for today, I'm here in this shine country with a good sun. Finally, we have summer, so I wish you also these positive summer days. Let's start from the case report. Initial situation: female of 48 years old, as you can see, without bad habits. In anamnesis, she have metal ceramic bridge, which was installed more than 10 years ago, and regularly it falls out, and the patient fixes it with Corega. It's a special glue for removable dentures. She's already finished and cannot fix it anymore. She would like to make something stronger and normal prosthetic part. I recommend her to replace these roots, which not possible restore. But yes, it's possible, but it will not stay so long time, maybe 1 year, 2 years, and then again some falling out. You can see that they are really soft, they are destroyed and pointless. Also, we have some inflammation under the roots. This is how patient came into my office. This bridge was fixed with Corega. This is how it looks when I remove this bridge. You can see these particles of fixing glue inside the bridge and on the top of tooth number 25. This is the X-ray. X-ray, you can see small inflammation under the tooth 25 and the more bigger inflammation under the tooth 27. In the CBCT examination, we can recognize that this inflammation was really deep, and this inflammation already started to penetrate the sinus. So our planning with R2Gate, we would like to fix 2 implants and in the future put bridge. Tooth 25, easy busy, normal bone. Here you can see that in plants it was 4.0 on 8.5, but I changed this plan to put implant 10 millimeters a little bit more deeper to have a cortical stabilization with the implant and without any graft to make a crestal sinus lead. Tooth number 27, a little bit more interesting because we have a really narrow wall between roots. And I decide to do not play with this primary stability, because usually when we make this kind of extraction and tooth was red rush, treated by Resorcent, sometimes we have move it out with wall. So I decide to put implant palatally to have primary stability, and I would like to make even immediate loading. But when we discussed with this patient that needs some temporary bridge, she was not interested in it. She would like to have just implants and at the end final restoration. So in the tooth number 27, have planned 4.5 and 11.5 millimeters implant. Here on the CBCT examination, you can see this penetration in the sinus. Already start to move in. Here on, you can see this bone quality. And day 0, our surgery day. It was, to be honest, I do not remember. I cannot see these parts and the numbers because of the right side window, but I think you can see them normally. I can see only 7 of, and then it's closed. Teeth was atraumatically extracted. It is the line part of surgery. Usually it takes maybe 65 or 75% of the time of all surgery what I have plans to make this implantation. So it was gently extracted. You can see that even this narrow wall between tooth number 20 inside tooth number 27 was left, but it's really thin surgical guide. Perfect fit, brilliant fit. Tooth 25, the implant 25 fixed, 27 fixed, and this is the most quicker part what I like in implantation. Patient even do not recognize that we fixed already implants. Both implants installed, you can see it in occlusal view. It is in the same day. Here in the here the X-ray examination. Both implants I have fixed with a closed sinus lift without graft material. I just drill and then just push a little bit implants deeper. Also was taken connective tissue graft from maxillar tuber for tooth number 25, and for tooth number 27 I make an individual gum former with a composite and blue and gel on the top on it. Connective tissue graft was fixed buccally with a propylene 60, and also this gap between the implant and buccal wall, which was wider than 2 millimeters, was closed with a xenograft. Also, the buccal roots, where it was before tooth number 27, was closed with xenograft, and without connective tissue graft, just fixed and closed with individual gum former. So this profile kept and saved. Lateral view, the same. And 2 weeks after stitching removed, you can see this healing. We have overlapping from the buccal site on position 27, but doesn't matter. We will wait until it will heal totally, and this gum will reduce a little bit. 2 weeks after lateral view, and it's day 147. How much it was? 5 months probably, because patient have another plans to and do not have plans to finish this work in 2-3 months after implantation. It was 6 months even. Okay, so we are ready for prosthetic part. I make some photo for my dental technician just with a Vita color. Yes, I know that before we work with gray card and so, and we make it, but as I understand, it's much better and cheaper work without it, and we have better results, and we make a complication, and we make more overloaded our workflow. So when I start my prosthetic part, I would like to check it twicely because of the palatal position of the implant. I make a scan and I make an impression and send these 2 options to my dental technician just to check up where is mistake, where can be mistake, analog with digital. But when my technician called me that, Dima, you know, perfect fit, perfect scan, and when he makes the zirconium bridge, he just tried to fix it on the gypsum model. He said no constriction, no counterangulation, everything is nicely and passive fit. Okay, let's try in the mouse. Installation of the zirconium bridge. It's with a screw fixation. Here you can see a lateral view, absolutely nice and acceptable about the color. And here on X-ray, you can see a passive fixation without screws. I just fix it without screws and make an X-ray to see, do I have some contraindications, counterangulation in the front or in the back of the bridge, but nothing. So I just fix it, and here we have as the outcome after 1.5 years, occlusal view, a lateral view. Here you can see even papilla start to move down between tooth number 24, 25, 25, 26. Patient absolutely satisfied. She even forgot that she have implants. She used them like own teeth. Here on the CBCT examination after 1.5 years, you can see that When I make a closed sinus lift, so just push a little bit more implant. The bone make corticalization on the top. Also, we have the same corticalization on the top of tooth number 27, and perfect view. Advantages and disadvantages. What from my practice? At first, it's a predictable prosthetic part, followed by predictable surgery. More time takes just teeth extraction. Screw retained natural looking teeth without artificial gum, in black triangles between teeth. An individual former helps to save this profile. And thanks to the navigation surgery, the speed of implantation is reduced to the minimum. So most of time we remove the teeth. Disadvantages. In my practice and in my daily workflow, it's sometimes difficult to use surgical guide in the posterior area, especially in the second molars, when patient cannot open normally mouth, or for example, if we have long crowns which can be moved a little bit up, so my hand piece with a drill cannot be fixed under the template to put in correct way. And what I have also, it's my point of view that it's possible balancing of the surgical guide, even if you have some retention lines, when you work also in the posterior part to put the implants in the second molars, if you do not have wisdom tools, which help you to support it, not jumping a little bit. But another option, you can use anchor pins. But anchor pins also, sometimes it's not comfortable and not convenient to put more palatally or from the buccal side, especially when patient, for example, have some vomiting reflex, when you need to remove it more quickly and you must to react more quicker. It is the end of my case report, but what I would like to say is that no matter how difficult it's at work, difficulties, complications, doesn't matter, it's our workflow. Everything always works at home. My greatest asset is my family and children. And when you are a dentist, unfortunately, even the weekend leaves its mark. I would like to share with you how tear off my eldest son's first baby tooth. Just some fun. Thanks to his godfather, he just bought quite fresh Mustang, so we can borrow. And finally, it's done. Why I show you this last video and why I shared before some difficult case and some kind of video. What's wrong with me? Yes, some presentation and why it's so. In order to have simple understanding that there is a complex operation with a closed sinus lift, possibilities of getting complication when you have primary stability, do not achieve primary stability in the work, you need to simplify it. You need to simplify it as much as possible. And the surgical template in particular has reduced the lion's shift of this operation. It's in my practice, yes. And if to complicate something, then only for fun and for unforgettable memories. Thank you very much. It was really pleasant.
Recording stopped.
Thank you so much. I hope you don't do this with your patients with a car.
The next tooth, he's waiting when we take it out with drone, with this drone, you know.
Okay. Good.
So judges, any comments and questions?
No, thank you.
Thank you very much. Have a nice day.
Okay.
See you.
Bye.
Okay.
Bye-bye.
Thank you. Bye.
Hello, everyone. And I hope you are not bored yet. So I'm the last one, so I will try to be fast and clear. So my name is Evelina Ginevičiūtė, and I am from small but beautiful country, Lithuania, and I'm oral surgeon. And I cannot start my presentation without saying thank you for my mentor, for my teacher, for my friend, Professor Tomas Linkevičius. And after 10 years, we are still together and we are the best team. So thank you one more time. And now let's bring you back to one memorable Monday morning. It was about 3 years ago. I was in my office when I heard someone screaming and shouting, "Help me, please, I cannot sleep, I cannot eat, I'm drinking only medicine, so help me." And it was my godmother. So I cannot say for my godmother, wait or come tomorrow. So we made examination, and after this we noticed that the problem is upper first molar. So in the X-ray, you can see that we can suspect something apically, but not something very dramatic. And after CT scans, we see that she really had pain, because we see how big inflammation we have apically, and the infection already resorbed all bone apically and even sinus floor. So we decided to remove this tooth. And after removing what we had nothing. We had really just a big hole without any bone apically. So you can see how easily we can go to the sinus straight from the mouth. So we had about, I don't know, more than 1 millimeter of communication to the sinus. So what next? What next? What we have to do now? So I asked this question for my colleagues, asking, so what would be your treatment plan for this case? And majority of them answered that I will suture the socket and I will make the late implant placement. Other colleagues said, I don't know, I don't care, I will send it to the surgeon and he can do whatever he wants. And I'm not surprised, because I also was learned in the university that if we have communication with sinus, and if we have so big communication with sinus, so the gold standard of treatment is to close this communication with different flaps designs. So you can see here, for example, it's flap from the palatal, and you can see how big, how difficult, how painful is this operation for patient. For example, patient will be thinking about you 2 weeks more after this operation, and it can cause swelling, hematomas. So it's really traumatic operation. And here you can see another flap design. It's from the buccal side. And I'm not saying that it's not working. It works and works very good. But what we have after healing, and we have nothing. We have zero bone. I'm not talking even about soft tissues here. And if we want to have tooth here in this place, so we have to make sinus elevation, bone augmentation, surgeries with soft tissues, implant placement. So these operations are also big, painful for patient, and it lasts. It lasts maybe for 1 year. And I love my godmother, but I didn't want to have here in my office for 1 year every day. So what I did, I made immediate implant placement in this case. And I'm very happy that already there are a lot of cases, a lot of studies about immediate implant placement, that it's safe treatment. For example, in this study is saying that immediate implant placement has more than 98% of success rate. So it's really successful treatment, and we can believe it in it. So we can go back to our case. And I think that a lot of us knows that if we want to have successful immediate implant placement, so the most important factor is primary stability. And how we can achieve here primary stability when we have zero bone apically. So the answer is very simple. It's white implant. And I know that there is also different opinions about white implants, because a lot of doctors are saying, do not use white implant. You will have failure. You will have big bone losses, especially in buccal plate. But I don't agree, because also there are a lot of cases with white implants. For example, in this study, you're saying that after 7 years, so it's quite long period, 7 years with white implants, we have only 0.19 millimeters of bone loss. So it's just nothing. So I can say one more time that we can and we must use in some cases white implants, and it will be successful. So we can go back to our case. So how we started. So we placed collagen membrane apically, and it was working as a barrier between sinus and the mouth. Then we placed the implant, white implant, in the socket, and it's immediate implant placement. So when we are doing immediate implant placement, so we are always doing bone grafting for soft tissues, to maintain soft tissue. So this case was not an exception. So we made bone grafting, and as you can see in the photo. And now also very important step, if you want to have not only successful immediate treatment, but also aesthetic, so you have to make individual healing abutment. So we managed to have a good primary stability here. It was about more than 50 newtons per centimeter. So we made healing abutment from composite and put it on the implant. So what we have after 2 weeks, so we still have implant in our mouth, but look how nicely it's healing. Look at the soft tissues, look at the contour, look at the bone. So it's good. And what is more very important, that patient had no pain, no complaints, no swelling, no sinusitis, and even no nose running. And after 4 months, only 4 months, and operation lasts only 40 minutes, we have results like this. And this is the buccal view. So we managed also to keep papillas here. And now I know also that a lot of doctors are saying that composite is not good for soft tissues, that we have very good materials like zirconia, like titanium for healing abutments, but even composite, if you are using it good, works perfectly. And here you can see articles about this that is saying also the same. Use correctly composite and it works. And this is outcome after 4 months when we take off our healing abutment. And I'm repeating, but again, look at the contour and look at the soft tissues here. And this is occlusal view after just 4 months. So we managed to have implant, we managed to save contour, soft tissues, and bone. So what we have to make now, just to make a final crown, and we made it from zirconia, super polished zirconia. And this is delivery day. This is a final outcome. And I even don't know what to say here because it looks like natural tooth just after 4 months. And this is the view from the buccal side. In the X-ray, we see that implant is fully integrated, white implant, and without any bone losses. So maybe you can say that it's just 4 months, so it's a short period, but even after 4 months, we have results like this. But how it looks after 3 years? And I can say that after 3 years, we have even better soft tissues. You can look here, and we have fully completed papillas here. So after 3 years, the results are even better with this operation. And I also want to remind you all steps. So look again at the first day and the contour at the soft tissues, and after 3 years. So it's completely almost no changes. And maybe you want to look at the CT scans. So after 4 months, yes, we have implant, we have some bone around the implant. And after 3 years, look at the quality of the bone. And I want to remind you also that we didn't have bone here at all. And now we have everything here. And what is also very important, no changes in the sinus. So how we can make this case better nowadays? Maybe we can have some more soft tissue friendly materials. And yes, we have. Yes, we have now. It's anatomy healing abutments from titanium. And if you do not like composite, if you don't know how to use composite, so use titanium anatomy healing abutments. And as you can see in this case, it works also perfectly and good, and you can be calm. So in the end, I want to ask you, so what would be your choice for your godmother to take this big, difficult, painful, costly, long-lasting operation, or 4 months and result like this? So this is my godmother smiling after operation and saying thank you for me. I'm saying thank you for you. And I want to end with one sentence that always do what you're afraid to do. So thank you.
Recording stopped.
Thank you so much.
Thank you for your presentation. So judges, any comments?
No.
I would have one question for Evelina. Evelina, how did you create a barrier between the socket and the sinus cavity?
Yes, as
you
I
place the
mentioned.
implant. You place the
No.
implant.
No, first of all, I placed that collagen membrane. It was like a wall from the sinus. Then I placed a little bit of bone, it's just for the height. Then I placed implant and then again bone around the implant. So it was a thick membrane, collagen membrane. It was, yes, working like a barrier between that and that.
Yes. Without any fixation, just being lucky, not going anything in the sinus. Okay, so lots of prayers. Thank you.
No.
Nice result.
Yeah, really.
Any questions?
No, thank you so much.
Thank you.
Thank you.
Okay.
Good day.
Thank you for